lip balms, and if you want to bring your comfort slipper or your pillow or your teddy bear or your music, etc., that's absolutely fine. You each have a private room and it's pretty safe, but again, it's a hospital, you know. Arrival time would be given to you on the day that I meet with you in the pre-op, but things can change, and usually, you know, the surgery can take a couple of hours, but if we went into surgery and there were adhesions or other findings and the case took 3 hours and something happened and there was a delay, if the surgery date or time rather changes the day before, we call and let you know, look, can you come a little later, or there's a cancellation, can you come a little sooner? So we will always notify you, and I will always come and say, look, I'm sorry, you know, you're supposed to be at 4:30, but it seems that it's going to be at 6:30 or something. So that's an incentive spirometer. Here, you're going to be working with that during your hospitalization every hour. It's a little device that you hold and you take a deep breath, and as you take a deep breath, this piston moves up and this little ball, is a ball valve, oscillates, and you want this ball valve right in the middle where there's a happy smile. If you go too, so what that's telling you, if you take like a fast deep breath, this oscillator will go way up, and that's not the purpose. If you're not going to have any other invasive things done while you're awake. Once the anesthesiologist puts you to sleep, all the other things follow. So the anesthesiologist will tell you, okay, you're going to go to sleep now, so good thoughts. The stuff that they'll give you is an agent that can burn the vein a little bit, and some of you will say, oh, ouch, ouch, just for like 10-15 seconds. Some of you don't have any issue with it, but most of you won't remember it afterwards. So again, if you do experience that, just okay, I knew about this, okay, this is it, Hawaii, Caribbean, whatever it is that you want to think about, and you go to sleep. Now, once you sleep, this is what's going to happen. They put a tube into the lungs. There's a tube that goes into the mouth, into the stomach. There's a tube that goes into the bladder from below. Okay, that's going to be your Foley catheter. And then you get a second intravenous line put in. And that's about it. Once you are positioned on the operating table, you will be covered from chest up and from pubic hairline down. So nothing is exposed except the abdomen. So, you know, some of you are a little concerned that you're going to be exposed fully, not at all. And the part that we work in is the mid-torso, and that's going to be where everything is prepped. The drain, well, some don't seem to mind it, some hate it. And I would say the pain from the drain is probably the most annoying thing out of all the 5 incisions. Patients who have bypass, your drain is on the left side of your body. Those who have the sleeve, the drain is on the right side of your body. And those of you who have band don't have drain at all. But you have the port. And the port site is what hurts, where the actual implant is sitting. And as I mentioned earlier to you, the site of the drain seeps for the 2 days you're in hospital, and when the drain comes out, before you go home, that hole still will seep for a couple of days, just a little cranberry juice color. By the time 48 hours after discharge, that scabs and you can leave it exposed. The site where the implant is with the band is going to be sore for a week or 2. And as it gets further away from surgery and that port embeds in the implants and tissues scar around it, pain gets better and you feel more comfortable. But those are the things that you need to expect. Also, the drain, whether it goes on the left side or on the right side, it's always sitting underneath the left diaphragm, high up in the almost area of the chest. And when you take a deep breath, a lot of you will experience that it catches your breath and you feel pain in the shoulder, because that's the same nerve. And that is something that I want you to know so you don't panic, okay? And I know the nurses give you cold compress, hot compress, massage. Unfortunately, it doesn't really help. It perhaps makes it a little better, but it will go away as soon as the drain is removed, okay? After you look at that abrasive area, it weeps like tears. The same thing happens inside. When you cut tissue, it weeps and it kind of secretes this natural solution, and that's what the drain captures. And also is a window for us to look inside to the abdomen, not literally, but if we start to get like green bile, then you know, okay, there's a leak. Or if you start to get lots of blood, then you know that there's a problem. So it's a window for that 48 hours to make sure that everything is good as planned. Because if you're in a situation where you have no drain and you drop your blood pressure, let's say, you're just not aware necessarily always, or if you have increase in your heart rate, what's going on? Are we missing a leak? Is there blood loss? Is the person in pain? Is the person dehydrated? It becomes a little bit of a guesswork, and you may end up getting the CT done just to ascertain that. Whereas you have the drain, often you may not need to do any of those things. You see there's not much coming out of the drain, or you can find out what's going on. And so it's a nice way of looking into the belly, but you know, can you do without it? Yeah, I mean, sometimes I take it out after first night now, because sometimes you guys hate it. But I like to try and negotiate with you to keep it for the 2 nights. But you know, often I go to the room before even saying hi, how are you? The first thing, can the drain come out? You know, can the catheter come out, right? So we have it. But if you can and you cope with it, it's better to have it. And if not, then we'll take it out after first night. So at this stage, when you're drinking, you can start taking pain meds by mouth. A word about the pain pump is that it has a little button on it. You press that and you hear buzz, that means the pain med was delivered. If you press that and you don't hear it, it's not delivering it. So if you keep doing that and you don't hear it, there's no pain med going. You just got to tell your nurse. And they will know because they check how much you've used. But remember that the first night you have the pain pump, and you use it as you need it yourself. You're in control of it. But the next day, you be given pain meds by mouth. These are written for you to be given on your request, not given to you round the clock. And the reason why that is we want to make sure that they don't keep giving it to you and over-sedate you, because we want you to have nice awake sessions where you're taking nice deep breaths. And therefore you have to ask, and you can get every 3 hours something. So if you need it, ask for it. Don't be brave, because you don't want to be sitting there suffering and not going for your walks because you feel uneasy or uncomfortable. Every 3 hours take something, and the first day is often pain levels between probably 5 to 7, and the second day is gone down to 3 or 4. By the time you go home that evening, it's down to 1 or 2. So you really want to make sure that you take the pain meds and you do your breathing and you do your walking and you do your sipping that first day as much as possible. For those of you who are worried about the catheter coming out, it's really not a problem. Catheter gets taken out in the morning and you can then go to the bathroom, and the first pee may be a little harsh to start sometimes, but typically it comes right back. And then the drain, for those of you who are absolutely miserable, I guess we can take it out that night, but most of you will be the next day. Okay? On the second day, you're going to be doing more of the same, just more of the incentive spirometry, more of the walks, more of the fluids. Instead of a half, you're going to have the full little cup, and you take that every 15 minutes, and you're going to continue to have the heparin, and you're going to have the IVs running still. And at the end of that day, if you've taken 2 16-ounce bottles of water, you should be good to go home. Discharge typically is late in the evening. Now, the band patients actually get to go home day 1. So they would have gone home ahead of the bypass and the sleeve patients. The sleeve and the bypass patients will go home the second day. And at the end of the day, 9 or 10 p.m., if everything is good, you'll go home. Okay? So for those of you who come out of town, you might want to stay in town here locally before you drive another couple of hours home. And for those of you who live locally, just make sure for someone, and for all of you, if someone picks you up, you don't want to be taking a taxi home or drive home or walk home or anything like that. The things that you will need to continue in terms of medications. Individually, I will go over those with the patients on that discharge day. You go back on this med, you go back on that med, but you don't take these. I will also remind you of the vitamins that you need to take, which is coming up, which is the multivitamins, the B12, the calcium, and I'll give you a prescription for Tylenol, codeine, liquid, and for an antacid. Antacids come in a capsule, and if you remember earlier, I said what you do with these, you open them up and you put the granules into a spoon with some applesauce or low-fat yogurt. You take one content of a capsule every day for 90 days. Some of you assume that that's for reflux and for indigestion, and you say, Doc, I felt great, I didn't have indigestion, I didn't take it. That's not what it's for. It's to help just protect that pouch while it's healing, to reduce whatever acid is there, and to hopefully promote that good outcome. So you want to take that for the full 90 days. Things not to do. I will go over that with you on the day and just kind of go over it with you. So no heavy lifting, no bathing, no smoking, no anti-inflammatories, no hormones, no pregnancy for a year, no intimacy for a couple of weeks. It's a killer. Because when you guys come to the clinic, the husband looks at the wife looks at the husband. Who's going to ask the question? And of course, I'll tell you anyway, because I know it's a question that everyone wants to know. So a couple of weeks, it's probably best not to. Afterwards, it should be fine, just as comfort. Okay, I mean, if you're kind of a couple that one hangs off the ceiling, it's perhaps best to wait a little longer. But for the regular average intimacy, a couple of weeks is fine. Things to look out for. If you have a fever, if you have leg swelling or leg pain, if you have chest pain, shortness of breath, abdominal pain, persistent nausea, vomiting, just feel not right, anything like that, you can always call. Okay, you'll have my own cell phone number you can call the service, the office, no matter what. You have a question, you call, and the office after your discharge will always call you after a couple of days. And that is really one of the wonderful things that Mary implemented in the office, so that there's always someone there keeping a tab on you guys. So you have a question, you call, or just come back and see us sooner. But typically your first post-op visit is at about 2 weeks, and that's when we will see you. And then after that will be 3-4 months after, and then probably quarterly for a year, and then annually thereafter. Okay, and all of that stuff that I just gave you as a summary, you'll get the synopsis of it at your discharge. Okay, so that's your discharge, and of course then you're on your way home.